Hello friends, myself Dr. सौरभ गुप्ता, कंसल्टेंट न्यूरोफिजिशियन देहरादून। तो बेसिकली आज से हम अपनी एक सीरीज स्टार्ट करने जा रहे हैं, सिंप्लीफाइड न्यूरोलॉजी लॉन्ग क्लिनिक्स इन न्यूरोलॉजी। तो आज हमारा लॉन्ग क्लिनिक 1 है, जिसमें कि हमारा टॉपिक है अप्रोच टू न्यूरोलॉजिकल केसेस। तो पहले हम बात करेंगे कि कैसे न्यूरोलॉजिकल केसेस को अप्रोच करना है, क्या हमारा बेसिस होता है केसेस को अप्रोच करने के लिए, व्हाट हिस्ट्री वी आर टेकिंग, how we'll do the examination, then investigation and the treatment part. So we discuss in details every point. If you have any question, you can ask us in comments. After this video, we will discuss how to approach hemiparesis, how to approach quadriparesis, how to approach paraparesis, and subsequently we will discuss other neurological cases as such. So without delay, today I will start first neurology series approach to neurology cases. तो स्टार्ट करते हैं। तो बेसिकली जो न्यूरोलॉजिकल केसेस होते हैं, व्हाट इज द मेन बेसिस इज द लोकलाइजेशन। इन न्यूरोलॉजी मेन इज द लोकलाइजेशन ऑफ द डिजीज, ऑफ द etiology. So where is the lesion localized, what is the cause and why this lesion occur. So we will start first is the basis of the neurology cases is the neuroanatomy. Neuroanatomy. So for approaching the neurological cases, we should know the how the neuroanatomy work. So for neuroanatomy, basically neuroanatomy start from the brain, so in brain we have cerebrum, in which we have the frontal lobe, we have parietal lobe, occipital lobe in the posterior side, and the temporal lobe inferiorly. So we have brain, in which we have frontal lobe, we have parietal lobe, we have occipital lobe posteriorly, and we have temporal lobe. Each lobe have different function. So for every disease there is a localization area is maybe different. So after brain we have brain stem, in which we have the midbrain. This is the midbrain. Then we have the pons and medulla. So midbrain, pons and medulla, these are part of the brainstem. After brainstem, medulla continue as a spinal cord, and behind the brainstem there is a area which is called as the cerebellum. So this area is the cerebellum. So for neurological localization we have two systems, central nervous system and the peripheral nervous system. In central nervous system we have brain, we have brainstem, we have spinal cord and the cerebellum. Four parts in the central nervous system: brain, brainstem, spinal cord and the cerebellum. In brain we have frontal lobe, parietal lobe, occipital lobe and the temporal lobe. In brainstem we have midbrain, then pons and then medulla, and cerebellum, which is present posterior to the brainstem. So this is the part of central nervous system. Now we will see the peripheral nervous system. So in PNS या फिर in peripheral nervous system we have spinal cord, which is the part of central nervous system. From spinal cords multiple roots arises which combined in different manner and these are the roots which arise from the spinal cord. Then we have the plexus. Plexus arise from the different combination of the roots. After plexus, these forms the nerves. After nerves, there is a neuromuscular junction, NMJ, neuromuscular junction, and after that there is a muscles. So from starting from the roots, plexus, nerves, neuromuscular junction and the muscle, this is the part of the peripheral nervous system. ठीक है, तो till now we have discussed the central nervous system, CNS, and the PNS. So in CNS we have brain, in which have the various lobes like frontal lobe, parietal lobe, temporal lobe, and the occipital lobe. We have the brain stem. We have spinal cord and cerebellum. So these four are the part of the central nervous system. So any lesion which is seen in the brain, either in the brain stem, in the spinal cord and the cerebellum, considered as a lesion in the central nervous system of the nervous system. Then we have the peripheral nervous system, in which we have the roots. So any lesion in the roots, in the plexus, in the nerves, in the neuromuscular junction and in the muscle. So any lesion in the root, plexus, nerves, NMJ and the muscle, these are considered in the category of the peripheral nervous system lesion. So in neurology we categorize diseases system in two parts, peripheral and the central nervous system. So this is the basically anatomy, basic anatomy of the nervous system. So any lesion, any disease, any pathology, we are localized in part of the either in the central nervous system part or either in the peripheral nervous system part. So after it, so now after this we start the how we localize the lesion. So localize the lesion, we have three questions in our mind. First, for localization, so for localization, we have few questions in our mind. First, where is the lesion? Second, what is the lesion? And third is the why, यानी कि etiology. In what is the lesion, यानी कि pathology. And where is the lesion, यानी कि site of the lesion. So for every case we approach in the neurology, we should have three questions in our mind. First, where is the lesion, यानी कि site of the localization. Second, what is the lesion, यानी कि what is the pathology. And third is the why, यानी कि what is the etiology, why this lesion occur. So for where is the lesion, we will discuss the peripheral nervous system and the central nervous system. कि lesion localized in the brain, brainstem, cerebellum, spinal cord, root, nerve, plexus, neuromuscular junction and the muscle. तो lesion कहाँ से कहाँ तक localize है? तो where is the lesion? आपका brain से लेके from brain to muscle, कहीं भी हमारा lesion localize हो सकता है. तो where is the lesion? Brain to muscles. What is the pathology? What is the lesion? इनके what is the pathology? Pathology may be compressive. कोई चीज है, कोई लीजन है, कोई ट्यूमर है, कोई डिस्क है जो कि कंप्रेस कर रही है किसी चीज को, व्हाट नेक्रोसिस हो सकती है. मे बी द पैथोलॉजी मे बी द नेक्रोसिस, पैथोलॉजी मे बी द इन्फेक्टिव. सो इन पैथोलॉजी देयर इज मे बी कंप्रेशन, मे बी नेक्रोसिस, मे बी इन्फेक्शन, मे बी इन्फाक्शन. इन्फाक्शन हो सकता है एरिया का, डीजनरेटिव हो सकती है पैथोलॉजी. तो पैथोलॉजी में भी कंप्रेसिव, नेक्रोटिक, डीजनरेटिव, इन्फेक्टिव, दीज आर द इन्फाक्शन, दीज आर द पैथोलॉजी. व्हाट इज द एटियोलॉजी? देन थर्ड क्वेश्चन. सो फॉर एटियोलॉजी वी हैव एक निमोनिक, विटामिन्स. So for last, why? V for vascular etiology, maybe vascular etiology. In we have in brain like infarction, we have maybe infarction of area like acute cerebral infarction. B may have the ICH, bursting of the blood vessels. So for vascular etiology we have infarction and the vascular. I for infection. T for maybe traumatic, maybe कोई ट्यूमर, maybe toxin. A for autoimmune. M for metabolic oblique endocrine. In metabolic endocrine we have the diabetes, thyroid. We have in diabetes we have hypoglycemia, hyperglycemia. Thyroid may be hypothyroidism, may be hyperthyroidism. We have calcium abnormality, we have hyponatremia, we have hypokalemia or the hyperkalemia. I for iatrogenic. Iatrogenic, which is caused by the doctor, like medicine overuse headache, medicine overuse headache. So in iatrogenic there is a maybe the drug induced causes like medicine overuse headache, medicine induced neuropathy, which is caused multiple cancer chemotherapies drugs. N is for nutritional. In nutritional we have vitamin B1 deficiency, B12 deficiency. Vitamin B12 deficiency is very important for the neurology point of view because it may causes dementia, forgetfulness, may causes irritability, may causes depression, may causes the neuropathic symptoms. B6 deficiencies also may causes sometimes neuropathies, and sometimes in nutritional there is a alcohol overuse which may also a cause of dementia or neuropathy. As for the syndromic. In syndromic we may have genetic diseases like Huntington chorea, like spinocerebellar ataxia. We have hereditary causes. So as for syndromic, in which genetic and the heredity. So for etiology, why this lesion occur? Vascular, this may cause infarction and the ICH, hemorrhage. Infective, T for trauma, tumor and toxin. Autoimmune like GBS, autoimmune encephalitis, multiple sclerosis, these are the autoimmune diseases. Metabolic, endocrine like diabetes, thyroid, calcium, sodium. Iatrogenic, medicine overuse headache, medicine induced neuropathy. Nutritional, vitamin B1 deficiency, B12 deficiency, B6 deficiency, and the syndromic in which genetic and hereditary causes. So out of 3 questions, first is the where is the lesion, second what is the lesion, what is the cause, third is the why this lesion occur. So for this we should understand this and should keep in the mind. So after this we start the history taking. So for all these questions, where, what and why. So for all these questions to answer, we required a good history and examination. So to answer these questions, we will require a good history taking in neurology and a good examination. So we start with the history. For history, सबसे पहले we have the chief complaint. So I will not discuss the basic of the history taking. Like in history, we will ask for the patient name, age, sex, religion, occupation, socio-economic status. So this is the basic part of history as MBBS or MD students should know. So after this we have the chief complaints. So अगर हम बात करें neurology point of view से, so there are few are the main symptoms in the neurology. Like there may be the fever, headache, vomiting, weakness of lower limb, weakness of 4 limbs, weakness of all limbs, weakness of one side of body, maybe seizure, loss of consciousness, altered sensorium, maybe the vertigo, maybe the some movement disorder, abnormal movement may be there. Walking difficulty. So if we will discuss with about the neurological symptoms, क्या क्या neurological symptoms हो सकते हैं, तो there may be a fever which is seen in the infective etiology, headache may be seen in the traumatic etiology, may be seen in the vascular etiology, may be in the infective etiology, in tumor also, vomiting may be seen in the various type of neurological disorder, weakness of lower limb like paraparesis, weakness of all 4 limbs quadriparesis, weakness of one side of body hemiparesis, altered sensorium, loss of consciousness, seizure may be a neurological symptoms, vertigo, and the any abnormal body movements or walking difficulty or incoordination in the walking. So these are the maybe the various type of chief complaint in the neurological patient. So for chief complaint we will ask for 3 questions, like for chief complaint, onset, duration and the progression. So after chief complaint always we write in the order sequentially. So chief complaint first आई हो first, then second, then the third, and we also mention the duration of that chief complaint accordingly. After chief complaint we have history of present illness, history of present illness, In this, we elaborate our chief complaint one by one with, like, we have history of complaint of the fever. So we mention, like, I have presented the case history of this with chief complaint of fever since 20 days. So in history of patient illness, we mention patient is asymptomatic in how many days, patient complaining of fever since few days. So we will mention onset, how's the onset, progression, duration. If we main focus on the fever, we will also for the variation, diurnal variation, like fever is intermittent, fever is continuous, or fever is कोई पैटर्न फॉलो तो नहीं कर रहा था, फीवर लाइक अल्टरनेट डे फीवर आ रहा है, इवनिंग राइज टेम्परेचर है, फीवर के साथ में एसोसिएट सिम्टम्स तो नहीं पूछेंगे. तो आफ्टर हिस्ट्री ऑफ इलनेस, प्रेजेंट इलनेस, इन डिटेल वी डिस्क्राइब ऑल चीफ कंप्लेंट इन डिटेल्स अकॉर्डिंग टू ऑनसेट, प्रोग्रेशन, ड्यूरेशन, कोई वेरिएशन, कोई टाइप ऑफ सीवियरिटी, इंटेंसिटी, पैटर्न, कोई स्पेशल करेक्टर अगर है, लाइक हेडेक में कोई थ्रॉबिंग करेक्टर तो नहीं था, कोई पल्सेटाइल करेक्टर तो नहीं था, कोई बस्टिंग लाइक करेक्टर तो नहीं था. सो फॉर ईच चीफ कंप्लेंट वी डिस्क्राइब इन डिटेल इन हिस्ट्री ऑफ प्रेजेंट इलनेस. आफ्टर दिस वी आस्क फॉर द एसोसिएटेड सिम्टम्स. Association of associated symptoms. So in associated symptoms, we ask, like if patient have fever, we ask for the any cough, any burning micturations, any headache, any vomiting, any neck pain. So basically in associated symptom, we ask history for the, in point of view localization or in view of etiology. So for etiology, we have vitamins in our mind. So etiology, we will ask question according to etiology, and for localization according to the pattern we will discuss in the past. Then we ask for the negative history. So negative history also for same, for the localization point of view and the for the etiology. Like if patient comes with the fever, we will also ask for the seizure in negative history. If seizure is not there, we also ask if there is any history of seizure is present or not, because if seizure is present, there is a localization in the brain cortex. If there is a involvement of the any vision loss, so lesion may be localized either in the optic nerve, either anterior optic pathway, either in the posterior optic pathway, optic chiasma, either in the occipital lobe. So negative history and the associated symptoms mainly we ask for the localization point of view and the etiology point of views. Like if patient have any type of neuropathy, so in negative history we should ask for any drug history, like many drugs may causes the neuropathy, like anti-tubercular treatment, chemotherapy drugs, they may causes alcohol intake history, you should ask any nutritional deficiency history, you should ask for the negative history to find out the etiology and for the localization point of views. So this is the negative history. After that we will ask for the personal history. Personal history. In personal history we will ask for the any addiction like tobacco, smoking and the alcohol. Then past history we will ask for the diabetes mellitus, hypertension, any thyroid, any asthma, any cardiac history, any history of the CVA. So any history related to the disease or any comorbidity like history of TB in the past. So in past history we will ask any comorbidity like diabetes, hypertension, thyroid, or any past history of similar illness or other illness. Family history, we ask for the family history of diabetes, hypertension and CAD and the CVA history. So personal history, past history and the family history. So this is the part of the history taking. So after history we will go for the examination. So after history, first we analyze the symptoms, symptomatology, and we will reach according to like provisional diagnosis after history. So when we elaborate the history, like we give the chief complaint, history of present illness, past history, family history, personal history. So after this we will reach to a provisional diagnosis. What is the symptoms and where we are localizing and what probable the etiology. So according to this we made a provisional diagnosis. After this we proceed for the examination part. So in examination, for neurological examination, we first of all see the general examination. General examination, we look for the vitals, we look for the pallor, icterus, cyanosis, clubbing, edema and lymphadenopathy. After this we will reach the CNS examination. So for CNS examination, first we see the level of consciousness. So for level of consciousness, we see the patient is conscious and oriented or not. Patient is drowsy. Patient is stupor, or patient is comatose. So first of all we assess the level of consciousness, like patient conscious oriented है कि नहीं है, patient drowsy तो नहीं है, patient stupor stage में तो नहीं है, patient comatose तो नहीं है. Because if patient is in coma or stupor stage, further examination of cranial nerves or detailed neurological examination like higher mental function is not possible. If patient is conscious and oriented, in that condition only we can do the full neurological examination like higher mental functions, memory assessment, lobar assessment. If patient is drowsy, stupor, coma, there is a difficulty in completing the neurological examination clearly. So for level of consciousness we also go for the GCS. So for GCS and for detailed consciousness assessment, you may see my previous videos on the GCS only. So we don't go for the details. After GCS we go for the higher mental function examination. Higher mental function examination. In higher mental function, we go for the attention, consciousness and orientation, attention, memory, speech, language, abstract thinking, judgment. So for detailed higher mental function, we don't go for the detail. For higher mental function detailed examination, you see my video on the YouTube, which is also present previously. So for higher mental function GCS, after that we go for the signs of managerial irritations. Signs of managerial irritation, then cranial nerve examination, cranial nerve examination के बाद में motor system examination. So cranial nerve examination पे भी हमारी ऑलरेडी वीडियो है, वो आप देख सकते हैं डिटेल एग्जामिनेशन के लिए. In motor system we do the nutrition, tone, power assessment, nutrition, tone, power. Then go for the sensory system examination. Sorry, in motor systems there is also the reflexes examination. So for motor system examination, nutrition, tone, power and the reflexes. In reflexes we have the deep tendon reflexes like biceps, triceps, supinator, knee and the ankle. We also have the superficial reflexes, abdominal reflexes, plantar reflexes, cremastic reflexes. So in motor system, nutrition, tone, power and reflexes. Sensory system, we go for the detailed sensory system, touch, pain, temperature, to other point also like vibration sense, joint position sense, 2-point discrimination, touch sensation. So for the sensory system, we don't go for the detail. So after sensory system, we go for the coordination or the cerebellar examination, so in which we do the nystagmus examination, past pointing, dysdeudocokinesia, finger nose test, rebound phenomena, pendular knee jerk, gait examination. Then after coordination is the gait examination. So for CNS examination, we first do the level of consciousness. Conscious oriented patient है कि नहीं, drowsy, stupor and the coma. We assess the GCS for find the level of consciousness. Then higher mental function examination, signs of medial irritations, cranial nerves examination, motor system examination, nutrition, tone, power and the reflex. In reflexes, deep tendon reflexes, the superficial reflexes. Then we go for the sensory examination like touch, pain, temperature, 2-point discrimination, ठीक है, vibration sense, then coordination and the cerebellar examination and the gait examination. So this is the part of the central nervous system examination. So after history and examination completion, we further go for the provisional or probable diagnosis. Because आफ्टर हिस्ट्री जो हमने प्रोबेबल डायग्नोसिस या डिफरेंशियल डायग्नोसिस पुट करी थी, आफ्टर एग्जामिनेशन हमारी लोकलाइजेशन कंपैरेटिवली इजी हो जाएगा, हम लोकलाइज इजीली कर पाएंगे. इटियोलॉजी पॉइंट ऑफ व्यू से भी हम कुछ इटियोलॉजी को आपस में रूल आउट कर पाएंगे. तो आफ्टर हिस्ट्री एंड द एग्जामिनेशन फर्दर क्वेश्चन इज द व्हाट नाउ इज द प्रोबेबल एंड द प्रोबेबल डायग्नोसिस. सो आफ्टर डिस्कसिंग दिस, नेक्स्ट पार्ट इज द part of the investigation. In investigation point of view, we have basic routine investigation. So role of routine investigation for the etiology point of view, especially like TLC, raised TLC seen in the infective lesions like bacterial meningitis, like septic encephalopathy, blood sugar level. So for hypoglycemia or the hyperglycemia may be the cause. For sodium, hyponatremia may be the cause. Potassium, like hypokalemic paralysis may be there. So basically role of the routine investigation and the nutritional investigation like vitamin B12, which may causes the neuropathy and sometimes maybe it causes the treatable causes of the dementia या reversible dementia. Thyroid, hypothyroidism. In hypothyroidism maybe the depression like symptoms, maybe dementia. So vitamin B12 and hypothyroidism both are the causes of the reversible type of dementias. Hyperthyroid like hypothyroidism may causes the periodic paralysis of the forelimbs. So we first go for the routine investigation. For other investigation we have the lumbar puncture LP, in which we go for the CSF examination. In CSF we see for the protein, sugar, cells. For basis of the CSF we will decide कि lesion is bacterial meningitis, viral meningitis or tubercular meningitis, or lesion may be demyelinating in which albuminocytological dissociation may be seen, or sometimes in GBS which is an autoimmune type of disorder or post-inflammatory. In this also albuminocytological dissociation is present in CIDP also. So we go for the special test for the in the CSF like virus, PCR वगैरह, encephalitis or autoimmune panel in the CSF, which may help in the diagnosis making of the specific viral encephalitis like herpes encephalitis, cryptococcal encephalitis, cryptococcal meningitis in tubercular cases also, and in autoimmune cases maybe some autoimmune etiology may be find out in the CSF. After CSF we have the neurophysiology in the investigation like NCV, nerve conduction velocity examination of conductivities, like in cases of neuropathy, in cases of GBS, in CIDP, in carpal tunnel syndrome, in femoral, in leprosy, in cases of the myalgia paresthetica, in cases of the foot drop, in cases of the wrist drop, radial neuropathy. So NCV is also playing important role in the making diagnosis and to find out the etiology of the case. EMG, like for the motor neuron disease, for the myopathy, for the denervation after traumatic plexopathy, for the NCV for the plexus also, for the plexus, EEG for the localized of seizure disorder, myoclonic epilepsy, primary generalized epilepsy, or the syndromic cases of the seizure disorders, or also for the hepatic encephalopathy, autoimmune encephalopathy, other cases also EEG is also important. Then brain imaging. Brain imaging, we have the CT head or CT spine, we have the MRI. MRI spine, MRI contrast, or MR venography, MR angiography. So for neurology point of views, we have various investigation like routine investigation, which may also help to find out the etiology of the lesion, etiology of the cause, like blood sugar hypoglycemia may causes loss of consciousness, may causes seizure, hyperglycemia may causes movement disorder like hemichorea, hyperglycemia may causes hemibellismus, hyperglycemia may causes the coma, hyperglycemic hyperosmolar coma. Sodium hyponatremia may causes loss of consciousness, potassium deficiency or low potassium may cause the quadriplegia like hypokalemic periodic paralysis, vitamin B12 deficiency may causes neuropathy, may causes the memory decline. Hypothyroidism is also may causes the neuropathy like carpal tunnel syndrome, compressive neuropathy may causes the dementia also. Hyperthyroidism may causes the hyperthyroid related periodic paralysis. CSF examination, we go for the protein, sugar cells, and the viral PCR or encephalitis, meningitis panel, or autoimmune encephalitis panel. For nerve conduction studies, neurophysiology में nerve conduction studies for the neuropathy point of view, peripheral neuropathy, GBS, CIDP, carpal tunnel syndrome, wrist drop, EMG for the myopathic disorder, for the motor neuron disease, EEG for the encephalopathy like hepatic encephalopathy, autoimmune herpes encephalopathy, for seizure disorders, brain imaging CT, MRI to localize the lesion to find out the cause like tumor, trauma, कोई infarction, कोई vascular lesion like ICH or the infarction. So this is the detail about the investigation for the neurology point of views. After this, we will reach the final diagnosis. So when we reach the final diagnosis after investigation, then next point is the what is the treatment and what is the prognosis. So after completing the history, examination, investigation part, examiner or teacher asks for the final diagnosis and what is the treatment available, what is the research available for that disease, and what is the prognosis. So for neurology cases, that is all from starting from the localization in the neurology, how neuroanatomy is important for us, how we localize the lesion, where is the lesion, what is the lesion, and why this lesion occur. So these three questions should be kept in the mind for history taking, for examination, for investigation point of view, for reaching the best and correct diagnosis, for correct treatment, and for telling the prognosis, how prognostication of the diseases. To summarize, we will go to the back. So this is all about our series. First topic is the approach to neurological cases. In neurological cases, neuroanatomy is everything. As we discussed, we have the two type of nervous system, like central nervous system. We have the brain, frontal lobe, parietal lobe, occipital lobe, and the temporal lobe. We have the brain stem, midbrain, pons, and the medulla, then spinal cord, and the cerebellum. This is the हमारा central nervous system. After this, we have the peripheral nervous system. The spinal cord से arises the roots. After root, many roots combine to form the plexus. After plexus, nerves arise. After nerve, there is a neuromuscular junction which goes to the muscles. So root, plexus, nerves, neuromuscular junction, and the muscles, these all are the part of the peripheral nervous system. After this, the central nervous system have the brain, brainstem, spinal cord, and the cerebellum. Peripheral nervous system have the roots, plexus, nerves, neuromuscular junction, and the muscle. After we have three questions in our mind. Where is the lesion? Site of the lesion, brain to muscle कहीं भी हो सकता है. What is the lesion? पैथोलॉजी यानी कि कंप्रेसिव पैथोलॉजी है, नेक्रोटिक नेक्रोसिस हो रहा है, कोई डिजेनरेटिव पैथोलॉजी है या कोई इन्फेक्टिव टाइप पैथोलॉजी तो नहीं है. Then we go for the etiology. What is the etiology for why the lesion occur? So for we have the mnemonic vitamins, in which we have the vascular, in which infarction, ICH, infective, T for traumatic, tumor, and the toxin. Autoimmune disease like GBS, multiple sclerosis. Metabolic or endocrine like diabetes, thyroid, calcium disorder, sodium, potassium disorders. Iatrogenic like medicine overuse headache, chemotherapy induced neuropathy. Nutritional causes. In iatrogenic may be idiopathic causes where we don't find the lesion. Nutritional causes B1 deficiency, B12 deficiency, B6 deficiency, alcohol intake disorders. S4 syndromic, in which we have the genetic disorder or the hereditary disorder like spinocerebellar ataxia, ataxia telangiectasia. Then so for all three questions we have history examination, because history examination अगर अच्छा होगा we will reach the diagnosis accurately and we find the treatment and the prognosis accordingly. So for first we go to chief complaint. Chief complaint in neurology may be fever, headache, vomiting, weakness of lower limb, weakness of all limbs, weakness of one side of the body, altered sensorium, loss of consciousness, seizure, vertigo, any movement disorder, tremor, any hypokinetic like bradykinesia may be there, rigidity may be there, and the walking difficulties may be the symptom. So for each symptom, for chief complaint, we will arrange in sequence order according to duration. We will ask for the onset, duration, and the progression. Then history of the pigeon delay, in which we elaborate each point of the chief complaints in details according to onset, progression, duration, according to character, according to variation with the time, variation with the day, you know, maybe to find out the better cause of that associated symptoms, and the negative history for localization point of view and for the etiology point of view. Then personal history for the any addiction, tobacco, smoking, alcohol, past history for diabetes, hypertension, CVA, CAD, tubercular, asthma, family history for the diabetes, hypertension, CAD, CVA और any genetic disease की कोई family history तो नहीं है. Then we will reach the provisional diagnosis after history taken. Then we go for the examination, in which general examination we see the vitals and other points of the general exam. Then the CNS examination, in which we have the first level of consciousness like patient is conscious oriented, drowsy, stupor, coma. GCS क्या है? For this GCS, higher mental function and clinical examination, you may see my full videos, full detailed videos on these points. So higher mental function, signs of mental agitation, clinical examination, motor system examination, sensory system examination, coordination and the cerebellar system examination, gait examination. Then we will reach the probable time. Then we go for the investigation, in which how routine investigation is important for the neurology point of views, importance of the CSF examination, importance of the neurophysiology like NCV, EMG, EEG, brain imaging like CT scan or the MRI. Then we reach the final diagnosis, and according to that we will start the treatment of the patient and what is the prognosis of the patient. So after this, हम आज की अपनी वीडियो को यहीं विराम देते हैं. अगर आपको कोई क्वेश्चन है तो आप हमसे कमेंट में पूछ सकते हैं. आपका कोई सजेशन है वो भी हमें दे सकते हैं. अगली वीडियो में मिलेंगे. मे बी हम अप्रोच टू हेमीपैरेसिस और अप्रोच टू स्ट्रोक के केसेस लेके। थैंक यू। इसी तरह से मेरी वीडियो को लाइक करिए, वीडियो को शेयर करिए, कमेंट करिए और हमारे चैनल को सब्सक्राइब करिए। थैंक यू।